Thanks, Ben. Hi, everyone. My name's Mara. I'm one of the teaching fellows at Alder Hey doing pediatric ENT. Today, we're going to go through procedural skills. And if you're doing ENT, you'll probably already have realised this, that you can't really do your job as an SHO or even a registrar without having some awareness about the procedural skills. Can we have the next slide? Thanks. So that's the session today. Can we have the next slide again, please? Thank you. So these are the procedures that we're going to cover. I will say definitely get someone to show you before you have a go, just because people give you really good tips on how to set the equipment up. And even if you want to do it for the first time, it's nice to have someone there just in case you get stuck. So we'll start with the ear procedures. And the first one is what we call microsuction. So this is different to syringing. So a lot of people think, in ENT to get rid of earwax or foreign bodies, we do syringing, which is where you basically have a machine that just fires water at high pressure in the ear, which does work, but there are slight limitations of that in that it's blind, you can't see what you're doing, and it can theoretically cause a hole in the eardrum. So what we like to use in ENT is actually a microscope, which you can see in this picture here. This gentleman is doing some sort of, I don't know, might be sucking up some wax or something under the microscope. And the reason we use a microscope is you can see what you're doing. It takes some getting used to. So if you find it difficult in the first instance, don't worry. It's good to try and examine as many ears as you can, even if you're not planning to do any procedures with the microscope, just to get used to it. So the reasons you might use it is A, for examination, B, to take out wax or foreign bodies. If the patient has an ear infection, such as otitis externa, or even otitis media, where the eardrum has perforated, you will not be able to see much. You'll just see a lot of discharge. So you can take a swab of that discharge under the microscopes, under direct vision, and you can also insert something called a poke pick, which I'll show you shortly, which is basically a very small piece of sponge that's quite hard when you put it in. And then when you take it out, it becomes really soft. And the aim of that poke pick is it basically stents the ear canal open. So patients with otitis externa, their ear canal basically does this. So it tightens on itself, which is why it's so painful. And the problem is sometimes if it's really, really bad, you can't get the eardrops in. So the aim of the poke pick, it's not medicated, it's to basically stent the ear canal open so the patient can get their eardrops in. You can also use the microscope to do several operations. You may see it used in theatre for grommets, mastoidectomies, rhinoplasty or tympanoplasty, which is a procedure whereby you repair the eardrum. And also if there's a lesion or a swelling in the ear and you want to take a biopsy, you can basically use the microscope. So those are some of the uses that you'll see in both clinic and in theatre. Can we have the next slide, please? So some things to just be aware of. Try and use the correct size of ear speculum. This sometimes is trial and error. Try and use the biggest one that you can get in. The aim of the ear speculum, so these are the similar sort of speculums that we put on an otoscope that you guys may be familiar with, but they're slightly more durable material, the ones that are in clinic. And the reason you put them in is so you can get a better view of the eardrum or whatever foreign body is in the ear, and it moves the little hairs in the ear canal out of the way as well. The patient can be lying down or sat up. If a patient's quite anxious or they're scared of feeling dizzy, you can get them to lie down. But in some clinics, for example, in Alder Hey, we just have chairs now, even for children, and it's absolutely fine most of the time. You will need to set your interpupillary distance. So the two lenses, you can basically change the distance apart so you can see directly down both of them, and how to zoom in, how to zoom out, and how to focus. In some clinics, they have a camera that they can attach to the microscope, so your supervisor can actually see what you're doing, which is quite helpful for educational purposes. So it's useful to just ask, because the first time you want to do some microsuction and take a foreign body out, you might feel a bit better if someone's watching and they can give you a few tips if you are struggling. Try and avoid touching the ear canal skin. That's when the patient will say, ow. And also if you cause bleeding, the problem is you won't then be able to see what you're trying to do. For example, especially for grommets, when you're taking the wax out before you put the grommet in, if you cause any small amount of bleeding, it can become quite stressful then, because you can't really see what you're doing. But there are always ways to overcome. If it starts bleeding, you can ask one of your registrars to show. You can get a little bit of a cotton wool, ball, soak it in adrenaline and just put it in the ear canal, and it'll stop the bleeding if it's that bad. And just be mindful, if the patient's lying down, they may feel a little bit dizzy. So just tell them to get up slowly, because what you don't want is they get up really quickly and then they go bang on the floor. Can we have the next slide, please? So these are some of the instruments that you can use for the ear, and they are angled so they can be used in the ear. So you've got the crocodile forceps in the middle. So these are useful if you want to grab something that has an edge, in, for example, some sort of foreign body that's quite hard and has an edge. It's not that if it's a bead, you need to probably get behind it. So I probably use a wax hook like you can see on the left. But if you've got like really hard pieces of wax or, you know, dead skin in the ear canal, you probably want to go with a crocodile forceps. You would put a Pope wick in using a crocodile forceps as well. You can physically just push it in with your hand, but it's easier to do with a crocodile forceps. There's a picture at the bottom of the ear speculum. The suction that we use from the ear is different to a yanker, because obviously a yanker sucker, what you probably have seen in A&E and on the wards, is too big. And as you can see, a lot of these instruments are angled to fit in the ear. So that's what we call Zollner suction. And you can use that in the nose as well if you needed to. There's something called a fine end, which is a small piece of plastic which attaches onto the end of the Zollner suction. So you basically just push it in. The reason you might put a fine end in is that if there's something really deep in the ear canal, or if you're going close to the eardrum and you need a little bit more length, so you could put a fine end on. Or if you want to reduce the amount of suction to the pressure, especially if you're going close to the eardrum, you need to be a little bit careful. You'd put a fine end in. But sometimes if something's too big, like for example, if it was really thick fluid or really thick wax, it might not come out with a fine end. So if you're struggling with a fine end, think about taking it off. And then you've got a Jobson horn probe, which is basically, you can use it for foreign body removal, but I find that it's best, one of its best uses, if you've got wax that you're struggling to get out, or some dry skin, you can just kind of fold it back on the ear canal just to improve your view. Can we have the next slide, please? Other things that are useful for the ears, if there's really, really hard wax, you're going to struggle to take it out. Also, if you pull on it, on the hard wax and it's stuck to the ear canal, it's going to cause bleeding. So if you're really struggling and the patient's not tolerating, you can put some sodium bicarbonate ear drops in, which is used to soften the wax. You can put a few drops in, leave the patient, go and do something else, give them 5-10 minutes and come back, and you might be successful. Or you can give the drops with the patient to go home, or tell them to buy it and tell them to use it for a week and then come back. Other things that you might see people doing, putting in the ear, is you can use a small bit of ribbon gauze that you can coat in any kind of steroid or antibacterial medication, and put it inside the ear for otitis externa, for example, that hasn't resolved, using a Pope wick and eardrops. You may also see people using something called BIP, which is a betadine soaked, iodine soaked ribbon gauze that is put in the ear after an operation. So it's a similar kind of thought process. And again, if you see ear discharge, take a swab of it. It takes 2 seconds and it'll basically help you treat the infection correctly, because sometimes it will be fungal and it may not be that obvious when you look inside. So if you keep giving the patient antibiotic eardrops, they're not going to do anything. Can we have the next slide, please? So wick insertion, we'll just show you a quick picture. So this is what a wick looks like. It's very, very small. You basically insert it in between the crocodile forceps and gently place it in the ear canal. You don't need to push it all the way in. The aim of it is to keep the ear canal open. Patients normally keep them in for about 48 hours and they'll come back and have it removed. Or what normally happens is, as the ear canal starts to open up, it may fall out by itself, which is actually a good sign. So if you discharge patient home and it falls out, tell them that that's basically nothing to worry about. It means that ear canal is opening up. So it depends where you work as well. Some places will leave the wick for a little bit longer. So when you start your ENT job, I would just check with your seniors what the practice is there. Can we have the next slide, please? So now we're going to talk about flexible nasal endoscopy, which is abbreviated as FNE. So if you see FNE in the notes or in the clinic letters, that's what it means. This is a very small flexible camera that goes through the nose to basically look at the back of the nose, called the postnasal space, and also the larynx, which is your voice box. It doesn't hurt, or it shouldn't hurt, but it's not the most comfortable thing in the world. So just warn patients, make sure you explain to them properly what it is that you're going to do. You don't have to use numbing spray, but some people like it. Or it's more, I think it's more the idea that they feel like their nose will be numb. Some people hate the taste of the numbing spray. So if they've had it done once, they may say that they don't want the numbing spray. And sometimes we have a sort of a lower threshold to use it in children because if it's slightly more numb, it may be slightly easier. The other thing to bear in mind is the blue spray, which has lidocaine and phenylephrine in, will decongest the nose. So if you've got a patient who has nasal symptoms, you probably want to see what the nose looks like without a decongestant to see what the turbinates look like, and how narrow their nose may be from the swelling. Because if you put the spray in, it will open it up and it may not be an accurate representation. And also always try and pop some Optilube on, or whatever lube you have in clinic. It just slides down a lot easier. The reason there's an alcohol wipe there is it just helps reduce misting because the air inside your nose is quite warm. Some places will have something called anti-fog, which is actually slightly a bit better. But if you can't find anti-fog, it's fine. You can just get an alcohol wipe. It's just useful as well when you're starting and you may not have scoped, and if your registrar asks you to get the scope, get some lube, get an alcohol wipe and see if you can get a blue spray as well. It's just quicker and more efficient. So how do you do it? It's pretty straightforward. The aim of the game is you're going to put the camera through one nostril. If the patient has a septal deviation, meaning this part of the nose, the septum is going one way or the other, try and go through the side that's a bit more open. You go, and we've got a really good video of Ben who's getting scoped himself. So when you go in the nose, this is what you're going to see. So that was one of the turbinates that there was an arrow to, and this is the septum. Try not to touch the turbinates. They are on the septum if you can avoid it. You can push past the turbinates as it will hurt the patient. We're along the floor of the nose, as you can see here. And then we've got we're in the postnasal space, and here you can see the eustachian tube openings. This is, again, where you may see some adenoid tissue at the back of the nose. And then at this point, you need to push, there's a lever on the camera to push down. Now you need to start pointing your camera downwards. And as you can see, we're approaching the larynx. So here you'll see all sorts of different structures. Those are the tonsils, this is the base of the tongue, and that is your epiglottis. And you slowly go down. At this point, if the patient is struggling and they have and they're finding it difficult, just reassure them, get them to take deep breaths through their nose. And if they have saliva or secretions, try and get them to swallow. Sometimes what also happens is the tip of your scope may get a little bit of saliva or debris on it. If you get the patient to swallow, it can remove that slightly. Or you can actually just touch something. So just touch the postnasal space very gently and it will just move whatever saliva is there so you can see. So the aim of the game with everything in ENT is you need to do it under direct vision. If there's too much snot in the nose, if you can't see, do not push the scope blindly. If there's a lot of snot in the nose, you can use a very small suction catheter and suck it out. But normally if the patient swallows and there's saliva, it will improve your view. And here you can basically see the vocal cords and a good view into the airway. So those are your tracheal rings that are coming into view now. Is that the end of the video, Ben? Yeah, we're going to the next slide. So when you have the patient with you, so you put the camera through the nose, postnasal space, then you want to go down. So gently push the camera and just check before you put the camera in the nose, because some of them are upside down. So if you push this way, it might not go down, it may go up. So just check that before you put the camera in the nose. Go to the postnasal space, angle the camera down, go all the way to the voice box. And then you want to ask the patient to do a few maneuvers, just so you can see everything. So if you ask them to stick out the tongue, you will get a better view of the base of the tongue, basically. If you get them to puff out their cheeks like this, you'll get a better view of an anatomical area called peripheral fossa. And you can ask them to sing or say E, R, count to 10. Then you're going to watch the vocal cord movements. So you just basically need to find a system that works for you. And you can get them to cough as well. Other things you can do, if you thought a patient was aspirating, for example, if you gave them a little sip of milk, the reason you'd use milk is you could be able to see it, because if you gave them a drink of water, it'll be difficult for you to see where that water is going. So if you gave them some milk and it looks like it's going the trachea, that would give you some evidence that they're basically aspirating. And on the SFO UK website, they have a really good website where basically there's a registrar doing a scope on a patient and they talk through every step. So that's a good one to just watch when you're on the job, just to remind yourself. We have the next picture, please. Sorry, next slide. So this is what the postnasal space looks like. It's important to know what it looks like so you know at what point you need to angle the camera down. And the anatomical parts that you'll see is here. You can see on the left one, there's the ET means eustachian tube, IT means the inferior turbinate, and then you've also got your fossa of Rosenmuller, which is a groove in the postnasal space. And some nasopharyngeal carcinomas actually come from this, so that's why it's relevant. Can we have the next slide, please? So this is just a label diagram of the voice box and the areas you will see. My best advice would be go to clinic and watch as many scopes as you can, and do as many scopes as you can, because most of the scopes in clinic will be normal. And then if you see enough normal ones, then you'll start to appreciate that things aren't normal. It's same with when you start to learn x-rays in medical school in F1 and F2. And a lot of places have the option to record the scope. So when you're starting off, it's a good idea. If you record your scope, you can always show the findings to one of your registrars, or even your consultants, just to go through, if you make sure that, you're not missing anything, because that's where a lot of anxiety lies. People don't want to miss things. So here you can see the epiglottis, and then you've got your true and your false vocal cords. And that's what TVC and FVC stands for. That was the piriform sinus or the piriform fossa that we were talking about if you ask the patient to puff the cheeks out. The postcricoid area is where your is basically where the esophagus opening will be. And this is also, if there is a problem, you need to basically know the anatomical point so you can describe if there is something that looks a bit pathological, if there's a foreign body, basically where it is. And the other things to be aware of is something called the vallecula, which is again a little groove that there's a little circle and a line towards it, and it's normally spelled vallecula with an E at the end, but I'm not sure if this is American or something. So don't worry if you don't know the points, just keep having a look, keep reviewing the anatomy again and again. When we do rigid scopes, so basically with the patient asleep under general anaesthetic, if you want to take a biopsy, it's the same anatomy, so just keep practicing. We'll move on to the next slide. So now we've got epistaxis. So nose procedures, this is one that people you'll probably be doing the most of this kind of stuff as an SHO. So with nosebleeds, always start with first aid. You shouldn't really be running in to pack a patient. If you have to pack them, that's fine. It shouldn't be the first thing that you do. And as a matter of them young children, you should not pack young children. If the young child is having a nosebleed that bad, they're going to need to go to theatre for an examination under anaesthetic, which is a rare occurrence. So where do you pinch? You need to pinch here, so the soft part of the nose. A lot of people pinch the bridge, but if you think where people normally bleed from, which is Little's area and the anterior part of the septum, you're not going to get hold on it up here. So you need to pinch here. You need to pinch hard. Get the patient to sit up, tilt their head forwards, get a sick ball for them to spit into, get some ice on their forehead and the back of the neck, and just give it time, 10 to 15 minutes. And a lot of the time, I've been on call as an SHO, you go and do some good first aid and the nosebleed stops. You don't always have to pack. And packs can be traumatic. So I would not pack someone unless you physically have to. The next thing you could do, so on the next slide, is cauterize the bleeding point. And in ENT, you've probably got the theme by now, you need your equipment before you can do anything. So this is why it's useful to just have an awareness. You can take a picture of this, and also it's being recorded just as a little guide. And it's also on the ENT SHO website if you completely forget. So to cauterize someone's nose, so this isn't bipolar cautery, the one that you'll be doing in clinic or on the ward. This is a chemical cautery using silver nitrate sticks, and they look like this. They sometimes come in a blue box, and it may be a different brand. Essentially, once you've used one, throw it away. They're not reusable, and make sure you only touch the septum with these. If you touch the skin, it can cause chemical burn, so just have that awareness. You need to numb the nose before you do anything. So the first thing you need to do is So if someone's bleeding really heavily, you're probably not going to be able to cauterize them because you need to be able to see what you're doing. If someone's had a nosebleed and it stopped and you can see a small bleeding point on the septum that you want to cauterize, this is when you would use this equipment. So you need some local anesthetic sprays, the blue spray that we talked about before. I personally find the best way is if you get some cotton wool, break it off, soak it in the local anesthetic spray and put it in the patient's nose and leave it there for a couple of minutes. Go and do something else for a bit and then come back. It works better than just spraying it, especially for children, because sometimes if you spray it for a child, it startles them and they get upset and they can taste it. So it's best to put it on cotton wool. Use a thudicum, a nasal speculum to basically widen the nose so you can get a good view. Again, get someone to show you how to hold the thudicum speculum best that you can and try and lift the tip of the nose. Sometimes if you just lift the tip of the nose and they've got wide nares, it's enough. You don't always need speculum. And then basically once you've numbed the nose, you want to touch the area. We've got a little slide on the next one as to what you would do. So then Ben, can you hear me? Because I think I've frozen on the screen. But can you still hear me?
I can hear you. Your camera's frozen.
That's fine, don't worry. So essentially, when you want to cauterize a patient, you want to decide where you're going to cauterize. In theory, you shouldn't cauterize two sides of the septum, so you shouldn't cauterize the right and left side at the same point because theoretically there's a risk of causing a perforation. Put your local anesthetic cotton wool there for a bit, come back. Make sure you've told the patient, even though you do this in clinic, you should verbally consent them. Tell them that there's always a chance that this can trigger some bleeding. Sometimes we don't know why they get a little bit of a bleed after 4 or 5 days, but which should settle with first aid measures. We've talked about perforation. It can stain the skin. Sometimes what happens is the silver nitrate mixes with some of the snot and it leaks out of the nose and it can stain the skin around. And that basically this may not work. But most people are quite happy to give it a go. Then what you need to do is use your silver nitrate stick to basically touch and seal the vessel. You should try and go around the vessel if you can to kill off basically any small feeding blood vessels to the main blood vessel and then do the middle. Then I normally put some Naseptin nose cream inside. So you basically just squirt it inside the nose. Always check with patients if they're allergic to peanuts because Naseptin has peanut oil in it. If they can't have Naseptin, that's fine. You can use something called Bactroban. And the other things to just remember are use a headlight when you're doing this because it's good to have 2 hands free. And you can use something called Tilly's dressing forceps, which was on the last slide, that to help you hold the cotton wool or any other instruments that when you're dealing with the nose, rather than using your hands and pushing things in. So if we move on to the next slide. So if that doesn't work, so first aid doesn't work, you can't cauterize it, they're still bleeding, you need to pack the patient. So there's various different types of packs. The ones that you probably are most likely to come across is something called a rapid rhino. That blue sleeve that you can see on the rapid rhino needs to come off. Please don't try and put the rapid rhino in the nose with the sleeve on, just because that's just a protective coating and it has happened. So make sure you take that off. I always, because these rapid rhinos have a balloon, check the balloon before you put it in the nose, because what you don't want to do is realize it doesn't work, take it out and put another one in because it's painful and it's uncomfortable to patients. So just use a 10 ml syringe, blow it up and then deflate it and then you can use it. You need to wet it a little bit before you put it in the nose, and once you wet it, it will start to swell. So don't wet it and leave it because then you will struggle to get it inside the nose. There's various different sizes of nasal packs. They start at 5.5 centimeters and there's 7.5 centimeters. One is 5.5 is the shortest. So if you think it's coming from quite anterior, you can put a 5.5 one. 7.5 is slightly longer, and then you also have one which is a double balloon one, which you can see on this screen as well. So that's what we call an anterior posterior pack. If you think it's coming from further back, then you would use this one. I personally, in adults, if it's that bad, I normally start with a 7.5 centimeter one because I was taught by someone that 7.5 in theory will go right to the back and press on whereabouts the sphenopalatine artery is. And it's better to put a 7.5 one in rather than a 5.5 and then take it out if it doesn't work and then put a 7.5 one in. But just have a chat with your registrars if you've not done it before. have a look at the different kit. Make sure you have different ones available, because what you don't want to do is put one in and it doesn't work, and then you're running around looking for another one. There's also one called Nasal, which doesn't have a balloon, it just has a string. How long a pack stays in is a very debated issue. Most places it's somewhere between 24 to 48 hours. A lot of places now, because of COVID, if someone's packed from one side and they're low risk, meaning they're not elderly, they're not on blood thinners and their blood tests are okay and the bleeding stopped, and they're a sensible adult, can go home and then come back to clinic to have the pack removed. But again, just check that wherever you work, because that's often a topic of high debate. I would always admit someone with bilateral nasal packs. I would always admit elderly people on blood thinners. Or if you think someone's just not going to cope at home because of the pain, it's probably kinder to just keep them in. We go on to the next slide, please. So if that doesn't work, then there's a traditional method of posterior nasal packing. So you can use the rapid rhino that we talked about with the double balloon. But say that didn't work, then and the patient's bleeding, you can use a Foley catheter, so urinary Foley catheter, to get to the postnasal space to try and tamponize the bleed. With nasal packing, always tell the patient that it's going to be uncomfortable, and they will scream in your face at times, and that's absolutely fine, especially when you inflate a pack or you inflate the balloon on the Foley catheter. That's normally what tends to hurt most. How you would do this, so if you're thinking of putting a posterior nasal pack in with a Foley catheter, your registrar needs to know. Because if this doesn't work, the next step is going to be theatre. So what you would do is have the patient sat up, get someone to give you a hand, suction the nose with a yanker anteriorly if there's any clots, push the Foley catheter through the nose and get the patient to open the mouth. When you can see the tip of the Foley catheter behind the uvula, that's when you know that you can inflate it. So put about 7 to 10 mils of air into the Foley catheter and then pull it back, so pull it towards yourself. This will basically place the balloon in the postnasal space. Then what you need to do is basically secure this catheter so it doesn't fall back into the patient's throat, because then they'll basically will struggle to breathe. So traditionally this is with an umbilical cord clamp. So if you can't find one, you're probably going to have to wander down to maternity, but put some gauze underneath the clamp because it can cause pressure necrosis. Then you always, anyone you pack or anyone with nosebleeds, always re-examine the oropharynx. So look at the back of the throat, see if you can see blood trickling down still, because if it is, you've not done your job properly. We'll move on to the next slide. So there's some newer things that are actually very useful, and I'd probably would try and use these before you put a pack in if you can, personally. So Nasal is a dissolvable nasal pack, and these are great. We use them in theatre after operations as well. And it's basically a sponge that you can use a Tilly's dressing forceps and put it in the nose. It comes in 2 sizes. So it comes in 4 centimeters, which is basically half of the one that you can see, and then 8 centimeters. They're pretty good. Basically, the benefit of it is that it's less painful, it's less uncomfortable, it doesn't have the balloon, and you don't have to bring the patient back to remove it. I personally, if the nose is quite wet and you've put one in and it's stopped, then it's fine, it'll start working. But Nasal needs some sort of liquid to activate it. So if you want to put one in as like a safety net, someone keeps getting nosebleeds and they don't want cautery for whatever reason, or if they're on a blood thinning, you don't really want to cauterize them, you can put a little bit of Nasal in the in front of the septum, and then just put 2 drops of Saline on it to get it starting. Always tell the patient they may have a little bit of pink discharge that comes out of their nose. That's quite normal. And little bits of it sometimes start to fall out, so that's also normal as well. Flow Seal is also another good one. They have it in most theatres. It's basically a hemostatic clotting matrix that becomes a liquid jelly. So it has various different bits inside it and you have to mix it up. And you basically just squirt it inside the nose and it should stop the bleeding. It has different extension pieces on the top. Some are shorter, some are longer. And this is a liquid, but it'll set, so you tell the patient not to blow their nose once you've put it in. Again, they can get a pinky nasal discharge afterwards. That's quite normal. The only thing with Flow Seal is if you put it in and it doesn't work, and the patient goes for an EUA, it's a bit of a nightmare to take out. You can take it out, it's just a bit annoying to do so. So in that sense, it doesn't mean don't use it, it's just something to be aware about, that it just kind of sticks to everything and it's a bit annoying. We'll move on to the next slide. Thank you. So we're just going to talk a little bit about draining a septal hematoma. This will most likely be drained in theatres, but it can be decompressed at the patient's bedside if the patient is willing. Don't try and pin the patient down if they're not willing. It's just going to be really difficult for everyone involved. The best way to do it, so different people will do it in different ways. I would put, again, your blue spray, so some topical local anaesthetic on some cotton wool and insert it into the nose. And then I would inject some lignospan or some sort of local anaesthetic as well into the septum. And then it's up to you whether you want to try and get a needle and a syringe and try and basically aspirate it. Or some people also put a cannula in it and kind of cannulate the septum and then just leave that cannula in, and it continues to drain. But often what happens is I feel like the cannula falls out because it's difficult to secure. If you can manage to decompress it properly, you need to put something in to stop it from filling up. So that's normally a rapid rhino pack on both sides, because as you can see, a septal hematoma 99% of the time should be bilateral, because a septum is technically one space. However, ideally, even if you decompress it, probably the patient will go to theatre, depending on how good of a job you've been able to do in A&E or at the bedside. So the next slide, we'll just talk a little bit about what happens in theatres. And this is just good, especially for any trainees. If you want to do the case, it's good to know what you're going to do, because I guarantee your trainer will ask you what you're going to do. So patient needs to be lying flat on their back, so supine on a head ring. It may be endoscopic, so may use a camera, but you can do it under direct vision as well. Whilst patient's in the anaesthetic room, you're going to again have some cotton wool soaked in lidocaine to get it working. Some people use a mix of adrenaline as well. Then there's two different places that you can do the incision. So you can either do a Freer's incision, which is where it says hemitransfixion, or a Killian's incision, which is slightly higher up. And you basically raise a flap and you get to the blood pretty quickly, and then you know that you're in the right plane. You then need to wash out that space with some saline. Some people will put a corrugated drain in. So this is a non-suction small piece of plastic. It's basically a small piece of a tube, which is on the bottom. It's at the bottom, and you'd cut it down, because you don't want a really big tube hanging out the nose. It can be really small, just to prevent it from reaccumulating. You would secure the corrugated drain with a non-dissolvable suture. Then you would need to suture the septum to basically close the space to allow it to heal. And then normally most places would put bilateral rapid rhinos in, which are removed in most places 24 hours post-op, but the surgeon should have written it on the operation note. And these patients will need antibiotic cover, because septal surgery, you really don't want to get an infection in your septum. It's difficult to manage, so they will need prophylactic antibiotic cover. So we'll just move on to nasal fractures next. So this is one that you can really get involved in. It's good fun as an SHO, and it's really satisfying the first time that you'd actually still remember the first one that I did as an SHO. So this is an MUA, means basically a manipulation under anaesthetic. And these patients are reviewed in clinic approximately somewhere between 7 to 10 days after the injury. And this MUA can be done with the patient awake or under local anaesthetic. Again, it varies on where you work. If it's an adult and they're quite willing, there's no reason you can't do it under local anaesthetic. And it's, you don't really use any instruments. You literally use your hands and push the bones back into place. You can use a piece of gauze to stop your hand from slipping, because when you're wearing gloves, it's easy for your hands to slip. If you wanted to put some local anaesthetic in, there's just a picture underneath the broken nose of some of the branches that you would probably want to infiltrate with some local anaesthetic. I would definitely say get someone to show you before you do it yourself. And normally we use dental syringes in ENT. just because they're quite fine. The thing you need to remember about a dental syringe and the needle is you cannot aspirate, so you cannot pull back to see if you're in a blood vessel. So you need to keep the needle moving. So I definitely say get someone to show you in the first instance. And if the patient, has an area where the nasal fracture is depressed, so if it looks like there's a little dent in the nose, the bone has gone down, you can use something called Walsham's forceps in the next picture we've got, which just basically lift up that piece of bone. And that's I'd probably say Walsham forceps are normally used in theatre, but I have seen people use them under local anaesthetic as well. The Walsham's forceps go inside the nose. So there's one part inside and one part outside the nose, as you can see in the pictures. So if you're going to put something inside the nose, I definitely put some local anaesthetic spray inside the nose. You wouldn't normally do that for an MUA under a GA, but if you're going to, with the patient awake, and you're going to use Walsham's forceps, I would definitely put, because it's a very sensitive area of the nose and it can be uncomfortable for the patient. And just a little reminder, anyone that comes to clinic for an MU with a broken nose, or even on the day of the procedure, double check for a septal hematoma, because it's surprising how often it can get missed. And as you can see, this is quite a nice picture of, you can see there's a black arrow which shows the direction of nasal displacement. So that was the way that the nose was basically bent. And then you're basically going to push in the opposite direction with your hands placed like that. But people have various different ways that you can push. But essentially, when starting off, it's good to use both hands. And if the patient's asleep, get someone to hold the patient's head still whilst you push. And you need to push quite hard to actually push the bones back in place. And the sooner you do this, the better outcome you will have, because the longer you leave a nasal fracture, the bones will start to set in place. We'll move on to throat procedures, so Quincy's. This is again another fun one, a really satisfying one. So you can drain a Quincy two ways. You can either do a needle aspiration, which is what I would probably say start with when you're new. And you can also do an incision and drainage with a scalpel. Again, it depends on the patient. Most patients will let you have a go because they're desperate to get better. The scalpel, the IND scares more people, and they might say, can you do it with a needle first? Most places you normally try and do a needle aspiration twice, and then if that doesn't work, or if it recollects, you do it with the scalpel. But I have seen people who just do it with a scalpel, so there's no right or wrong answer. Again, you need a kit and you need the right kit. So definitely have a headlight, because I have seen, if you don't have a headlight, then if you've got someone else shining a light in the throat, it's really not an ideal situation, because 9 times out of 10 they're not shining the light where you want it to be. Then what most people will do is, again, you've got your blue spray, so you just spray it in the back of the throat on the side where the quinsy is. And I think I've probably said this a few times, give local anaesthetic time to work. The patient is more likely to tolerate the procedure. Sometimes we're impatient, you've got so many things to do, you just want to crack on. Put the local anaesthetic spray in, go and do something else, start documenting, give the local time to work. You need a tongue depressor. If you can get a lax tongue depressor, which is a metal one, it's better because it's just a bit more sturdy. But sometimes you can't find one. They only have them in theatre, so a wooden one is perfectly fine. And then my personal favourite is a 10mm syringe and a 19 gauge needle. If you want to do an incision and drainage, I would inject with local anaesthetic. I wouldn't just spray and do it because it's going to be a little bit more painful. So if you're thinking you might do an incision drainage, find a scalpel, and if you can, you might need to go to theatres. You can get a mosquito or a small clip. So the next slide tells you how you basically do it. You need to take your time to assess the swelling. Make sure the patient's comfortable, sat up in bed, or there may be a chair in accident emergency. Make sure if they're on a bed, they're at the right height for you, because these things basically make a huge difference. You really don't want to be sort of repositioning the patient when you're just about to put the needle in. It just wastes time. Put your local anaesthetic spray in, give the patient time. And then what you basically need to do, so this is what people get really, really worried about. And this is basically approximate where you should be going. Sometimes it may look like it's bulging a little bit more, slightly under this point or over this point. I would go wherever it looks like it's bulging the most. But when you're first starting off, you basically need to imagine a horizontal line at the base of the uvula. So I don't know if Ben, you can just point out that line. So yeah, so that's the base of the uvula. Imagine a line across it. And then you need to imagine another line, which is basically at the medial aspect of the molar teeth. And that's where those two lines meet, is where you need to put your needle. Then you need to insert, once you're happy that the patient is, the local anesthetics had a bit of time, patient's happy to go ahead. I always say to the patient two things: try not to bite down. It's natural, it's painful, they will want to bite down. So just give them a little heads up that this still will be a little bit uncomfortable despite the local anesthetic spray. So try not to bite down and try and keep as still as you can, because what you don't want to do is then move suddenly when you've got a needle or a blade in their throat. That's not a good idea. And what should happen is you insert approximately 1/3 of the needle and pull back on the syringe. Which is, to be honest, a bit of a task. It takes a bit of time to get used to doing that. Eventually, I feel like you can do it with one hand, but you may need to use two hands. And there's no harm in getting your registrar or one of your colleagues to give you a hand the first time you do it as well. I personally loosen the syringe up a little bit and pull it back a few mils. I find it makes it easier to let the pus collect in it, and just keep pulling back until the pus stops draining. What you can do the first few times you do it, because I remember being petrified the first time there was a quinsy as an SHI to do it, because you're scared the needle's going to go too far. What you can do is the cap that covers the needle, so the sheath, you can cut that and use it as a guard. So that will basically stop you from advancing the needle too far. That's completely fine. You can also use some tape and wrap it around the needle until the point. So you need to wrap it with but still leave some of the needle exposed, and that again will stop you from going too deep. And once you're then comfortable, you don't have to use a guard or the tape. If you're going to use a blade, you basically need to make a very small stab incision at the same landmarks. It's basically the same thing. And you should get pus come away. If you don't, rather than stabbing any deeper, I personally take a mosquito or an artery forceps, the finest one that you can find, or a small clip, and basically just separate the tissue, and then you should get to the pus. If you're going to do an IND, or I would have a Yanker sucker at hand, because it's kind of like, I don't know if you guys have done gen surge. If you pop an abscess, it kind of goes everywhere. The caveat to that is it's in their throat, so they might start choking on the pus, which is not very pleasant. So just have someone on standby with a Yanker, so you can just get that in the mouth and suction up the pus. I definitely have one of the nurses or someone just by the patient side with you, giving you a hand. It just makes a world of a difference if someone can just pass you instruments. Is that all of them, Ben? I think I'm still frozen on the screen. I think we've got some, Ben's going to go through some interactive cases for you guys. I don't know if there's any burning questions in the interim.
I've just been answering some in the chat.
Brilliant, thank you.
Just the last one, I'll just answer it orally because it's taken a while to type, about how fighting the needle. I'm
just trying to start my video because I look so strange frozen.
As Amara was saying, it's approximately 1/3 of a needle, but once you've got an aspirate, you can stop advancing. The main thing not to do is to go right to the hilt of the needle, because you just want to remember that there is sort of the internal jugular vein sitting about 2.5 centimeters. So it's quite deep, but it is there. So
you've got your external carotid as well. So just, don't go crazy. And you can go a little bit deeper with the needle. It's just approximate. And the thing is, you'll start to get the feel for it, and you won't understand it until you get you do one successfully. It's kind of like you feel like you're going through butter. You feel like a little bit of a give sometimes. Then you know you're in the right plane. If you don't get flashback and basically the pulse back, you can just sort of rotate your needle a little bit medial, a little bit lateral. Don't fish around, but also remember, the reason we're using that needle isn't because we need to use the whole length of because the patient also, the other thing is patients see the needle and they're like, what the hell, you're going to put that whole thing in my throat. It's because a 19 gauge is quite wide, pus is quite thick. So that's why we're using a 19 gauge needle. It's not that we need the whole length, we basically need the diameter of the needle. So again, just reassure the patient, because a lot of times, you know, they see the needle and they're like, I don't want to have it done anymore. It's because you need, the pus is thick, and you need a bit of space. Some people use like a green or a blue. I'd say get a 19 gauge. It's just a lot, it makes your life a lot easier.
Cool.
Thank you.
All right, we'll start. So we've just got a few cases just to put what you've just heard about into action. So using the poll, so I'll just launch the first poll, and you'll have about a minute or so to answer. So we've had a 26-year-old man present with brisk epistaxis that's not resolved after 20 minutes of firm pressure, and you decide to pack the nose. And this is the gentleman on the right. So what type of pack are you holding? Is it anterior or posterior? And which direction should you push it? Right, I can see that's about half of you voted. So final 10 seconds or so. So this is actually a Maricel. So we're 50-50 between Rapid Rhino and Maricel. So Maricel's kind of like a foamy sort of structure, and it also you want to have, it tends to have a string sort of attached to it. Whereas Rapid Rhino will have a kind of cuff, and you inflate it with like a balloon. So that's the main way to tell the two apart. Nasopore, to be fair, it sort of looks similar to Maricel, but it's sort of a bit more flexible. And you wouldn't have a suture attached to it because it dissolves. You don't need to pull it out again. And a Foley catheter is obviously, it's just a normal urinary catheter, so it looks a little bit different. And you can see nearly everyone was right. Yeah, this is just anterior packing. So anterior, most nosebleeds are anterior, and sort of up to about 7 centimeters. When you're trying to pack what you suspect is a posterior bleed, it's using either, like we talked about before, like a double balloon Rapid Rhino, so they actually have 2 cuffs, or a Foley catheter. So there's different techniques. And then in terms of direction, we had a little bit of a spread, but the majority vote was right. So it's the blue arrow. So when you saw in that video earlier with the nasal cavity, what you're trying to do is sort of slide along the base of the nasal cavity, along the floor, backwards. And a good sort of way of, if you're trying to orientate yourself, is you can kind of try to stay level with the earlobe. So you're trying to just follow along the floor of it. So this time we've got a 72-year-old man on a Pixaban, presents to A&E with epistaxis. And after doing some first aid, you examine him and you can see a visible bleeding point. Where do you think the bleeding point is? What management would you like to try next? And what could you use as an adjunct? Right, that's half of you. Final 10 seconds or so. All right, and I'm going to share the results. So most of you are right, yeah. A's the inferior turbinate, C is just the floor of the nose, B is that bleeding point on the septum. So you're right, so we can see a visible bleeding point, and it's obviously not gushing with blood. So silver cautery is a good idea to kind of stop ongoing bleeding. And that's sort of a little chemical burn like you saw earlier. It's because this is quite anterior, you definitely wouldn't need to do posterior packing. Electrocautery silver nitrate cautery is a lot easier, it's less painful. You can do it on the ward in A&E. So that would be more advisable. And then in terms of an adjunct, so this is sort of variably used and depends what you have access to in your hospital. So something I quite like, if you've got someone like this guy who's on a blood thinner, so there's a bit more chance, I guess, of higher risk of bleeding, sort of when I quite like using an adjunct. So both Nasopore and Flow-Seal kind of at the top were both things that you could use. Nasopore being that dissolvable packing, so it's something people can go home with and doesn't need to be taken out or just dissolve away over a week or so. or flow seal, again, that sort of hemostatic mix that you can inject into the nose, again, doesn't require admission. So they can be quite a nice sort of second line on top of silver-night cautery in someone that you're a little bit more worried about. Topical tranexamic acid doesn't really have, there's no good evidence for using it in nosebleeds, although it is something people sometimes try. But certainly it's not an adjunct after you've done cautery. So here's an endoscopic view of the nose. So on the left, we can see the bleeding point, a nitrate cautery stick going in, and then this is kind of the normal appearance of the nose after cautery. So you'll see as you do it, it's a chemical burn, so the nose will change colour from that kind of pink colour to a sort of grey white colour as you burn it. And what you want to do is try and minimise the area that you're burning, so certainly not skin as you go in, and you want to try and just keep it as contained as you can around the bleeding point. And as Umara said before, kind of often it's a good idea to have a bit of a paper towel, or you can use Vaseline just to protect that upper lip from stuff running out to stop it being stained black. So this time we've got a 28-year-old man presents to A&E after being punched at a bar, and he doesn't have a septal hematoma. We've had a look. So when should he be seen by ENT? What management might you offer? And if you were manipulating, which direction would you want to push the nose mostly? All right, and I'm going to share the results. So when should they be seen by ENT? Most of you sort of said 5 to 14 days is the kind of time window that people tend to go for. So I guess you get a lot of phone calls about this when you're on call about people with nasal fractures, things to make sure that's been happened, if someone's checked whether there's a septal hematoma or not, because if there is, then you do need to see them today. And checking, obviously, this person's had a head trauma, so checking that people assessed, signs of skull-based fracture, so no CSF, not suspecting CSF leak, not got panderi, signs of more serious head trauma. But as long as it's just a deviation of the nose, then you're looking at seeing them within sort of a 5 to 14 day window. So the reason is you want to give them 5 to 7 days to let the swelling settle post-injury, to then look at manipulating the nose. And as kind of said before, as it gets past 14 days, the bones start to actually fix in the position, so you're much less likely to successfully remanipulate the nose. So most of you right there. Then management you would offer, we've got a bit of a split. Most of you saying manipulation under local anaesthetic, and a third of you saying manipulation under general anaesthetic. Then this is, again, a bit centre dependent, but sort of studies have shown kind of cosmetic effect tends to be quite equivalent between the two. And certainly in the centre that I work, we do pretty much all of them local anaesthetic and don't really offer under general anaesthetic unless there's sort of a very good reason why the person wouldn't be able to tolerate it. And there's lots of benefits. It's obviously cheaper, quicker, reduces burden on your waiting lists, more environmentally friendly, as I heard at a conference more recently. But yeah, both are valid options. And then in terms of direction you'd apply, so yeah, you can see the nose is kind of markedly deviated off to the right. So that yellow arrow is sort of the main direction of resetting. And there's sort of different ways of doing this. And as you say, if you've not done it before, would recommend getting one of your seniors to show you and sort of supervise you doing your first one. But sort of sometimes what I'd do is kind of, you can push a little bit the green way just to loosen the kind of fraction, and then sort of back across to centralize. But yeah, mostly need to follow that yellow arrow to recenter. Now we'll go on to case number 4. Oh, actually, you get before and after. So this is before manipulation and this is after. So you can get really good cosmetic results by quite a simple technique. So it can be really satisfying. All right, so then case 4. So I'll launch the poll. So this time we have an 18-year-old man presents with a severely sore throat. And this is his throat. What's your top diagnosis? Where would you like to try and aspirate if you want to? And what needle would you choose if you had a choice? Alrighty, I'm going to share the results. So yeah, we're looking, as 95% of you said, looking at a peritonsillar abscess, also known as a quinsy. You can see this deviation of the anterior tonsillar pillar, sort of deviated towards the midline. And then where you'd like to try and aspirate, we've had a bit more uncertainty. So we've got a spread. So it would be the way to kind of think about it. And I've got a diagram just to remind you on the next slide is when you're trying to visualize where to go, it's often a lot more lateral than you'd expect if you've not done it before. So kind of imagining a line from the top of the uvula across and from the medial edge of the molars up, which gets you to about C. So it's right off laterally. But as Amara was saying, as you kind of get more experience, you'll start recognizing points that are a bit more swollen and you kind of go for that. So B is likely to going to be too medial and a bit too high. And A, although it's deviated in, it's not actually where the collection is. That's sort of the deviated tissue, and the collection's actually lateral to that, pushing it in. And in terms of needle size, 85% of you, yeah, essentially the biggest needle. I mean, if you don't have a white needle, you can use a green needle. I certainly have quite a lot of times. It depends what you've got available, but the reason's just as Amara was saying, pus can be pretty thick, so having a big needle is just more likely to work easily. So this is what I was talking about, sorry, just with the lines across, so you can kind of put you in a ballpark. And if you don't get anything after the first go, it's reasonable as long as your patient's willing to have a couple of goes, so 2 or 3. And so that diagram, I've got it next. So here, points you want to try, so starting with that, sort of centering yourself a base where you think it most is, but if kind of willing, it's reasonable to try having a second and third go just a little bit higher or lower. Or in fact, if you've got some pus, but you think it's still very swollen, you think there's more, you could sort of try in that sort of area. And then we're on to case 5. So I'll launch the poll. So this is a 33-year-old man who's referred to the ENT emergency clinic with a 7-day history of sore throat. And you decide to scope him because you're worried you might have a collection, and you're provided with the equipment. So what's the alcohol wipe for? What's the typical route to pass the scope through the nasal cavity? Which nasal cavity is this? And what's structure A? All right, and I'm going to share the result. So yeah, a little bit of a trick question, but alcohol wipes tend to be, it's for demisting the camera on the endoscope. In terms of cleaning it, obviously there's different ways of cleaning it. It can either be sterilized sort of as per like theatre equipment, or you'll kind of tend to have like a 3-wipe pack for kind of cleaning it more thoroughly. So it's not just an alcohol wipe, but just check where you work what system they've got for cleaning endoscopes. In terms of demisting, you don't have to use an alcohol wipe. Another common way of doing it is by holding the camera on the tongue and letting it kind of warm up as a way of demisting. Alcohol wipes are good. Typical routes, 91% of you, yeah, typically following along the floor. So floor of the nasal cavity, obviously won't work for everyone. Some people might have a deviated septum or some kind of abnormality, but it's a good sort of first route choice to try. And it's also worth asking people, particularly if they've had scopes before, do they have a preferred nostril? Because people often, once they've had a scope done, will know if they've got a septal spur or, a deviation that makes one side more difficult. Which nasal cavity? So that's just orientating yourself. So, and it also answers structure. Question 4, what's structure A? So it's the inferior turbinate, as almost all of you said. It's A, and so then opposite, so that's the lateral wall, and then this is the nasal septum. So this is our left nasal cavity. So it's just kind of working through it logically. All right, and then we're going to see the next part of this scope. So you've got through the nasal cavity, and you are now having a look down at the throat. I think I've actually not saved this poll result. So does he have a parapharyngeal abscess? Yes or no? What's structure A and what's structure B? Sorry about this. I think I must have just forgotten to save this poll result. So we've got a few votes about the anatomy. So yeah, A is indeed the epiglottis, that sort of leaf-like structure that protects the airway. And B is a palatine tonsil. And then the question of, does he have a parapharyngeal abscess or not? Not seen any questions, but anyone want to pop it in the chat? No. Yeah. Arika's right. So this is just a normal airway. So things to kind of look for if you're worrying about abscess. In fact, I'll show you on the next slide. So it's things like this when you start getting asymmetry. So it's sort of a good way of thinking about if you're looking down the airway. Are the pharyngeal walls symmetrical? Are there any kind of protrusions is there any erythema? Are things to look out for. And then I guess it's sort of at what level are they? So can you look under it in terms of sort of peritonsil abscesses extending back or not? But this is sort of certainly something to speak to a senior about if you don't think it's symmetrical or you're worried. And a great time to have recorded it, as Amara said. So then we're coming on to our final case. So I'll share the poll, which I have remembered to save. So this is a 36-year-old lady presenting with epistaxis, and your registrar has asked you to insert a rapid rhino. So which is the rapid rhino, and what should she do next? And I'm just going to share the poll now. And I can see that most of you have got it right in terms of the A, B, C. So B, you can see he's got this little port for inflating the air up. So that is the rapid rhino. A being the Nasal again, and C being a Foley catheter. And you can see this is actually a double balloon, so posterior packing rapid rhino. And in terms of what you should do next, so this is just about how much air you should use. So it is air that you use to inflate a rapid rhino, not sterile water, which is a mistake I have seen done. And then in terms of, ideally you want to wet the rapid rhino just before you insert it, because it just helps. They kind of got a coat, so you take off the outer sheath, run it under tap, and it kind of becomes a bit more lubricated, so they slide in more easily. And then you're inflating, essentially it depends a bit on the size of the nasal cavity, but somewhere between 5 and 10, maybe a bit more, 7, 10 mils. So and you just want to check that there's obviously no bleeding going on after you've inflated it. I guess the trade-off, the negative with having more air in is it just does make it a bit more painful. And when you have packed people's noses, it's worth thinking about prescribing them some painkillers. So just things like paracetamol can help take off, because people can often get quite a bad headache if they keep it in for a while. So that was our final case. Thanks everyone for joining us. I'm going to pop the link to fill in a feedback form and get a certificate from today's session in the chat. As hopefully that was a helpful sort of introduction to it all. If you've not done these procedures before, we would recommend sort of getting watched, getting a bit of help first time, and also just checking what your local centre does, because with ENT there's variation depending where you work on what kind of approach people like you to do first with things like all of it really. Just check what the local kind of go-to is and what equipment you've got locally before you're in a panic looking for it.